Dormer here with lesson 4 in week 2, module 2, focusing on the history of regulation and legislation with respect to consumer health informatics. In this lesson, we focus on the Cures Act, the second of 3 lessons relating to the Cures Act. And this one is on information blocking. Information blocking is, as it says here, what is it and to whom does it apply? Information blocking is the practice by an actor. We'll define actors in a moment, really what we might think of as stakeholders, that is likely to interfere with the access, exchange, or use of electronic health information, except as required by law or specified in an information blocking exception. Well, that's not exactly perfectly clear. Let's linger on it for just a second. Recall that in the last lesson, we talked about HIPAA and the requirements under HIPAA not to disclose certain things about addiction or mental illness or certain medications, for example. This information blocking is the way in which, through the Cures Act, the industry tries to resolve privacy with the need to know in order to provide appropriate care. And so what this says is that information blocking is the practice by certain of the stakeholders to interfere with the information, except or unless that blocking is required or specified with one of a certain set, about 8 exceptions that allow you as a provider or someone with personal health information not to share it. And so you can see how important this is for us dealing with consumer health informatics. Are we receiving information that we need from an electronic health record into our consumer health application? Are we receiving the right information, all the information? And conversely, as we create or track or maintain that information, what rules apply when we share it back into the health information exchange, the health information ecosystem? That's what we'll talk about when we look at information blocking. So who are the actors? When they talk about actors, they talk about healthcare providers, health information organizations, which we've defined earlier, and certainly health information technology vendors. Who's not on this list? Patients, consumers are not on this list. I'm not fully sure what to make of that. I'm not sure if they're simply saying we offer no guidance, there are no restrictions on what you can do with your own information. But I find it odd that the consumer is not defined as an actor, as a stakeholder in this at all. It may be perfectly logical. I think we'll work through some of these issues as we go. But it's a significant election in how they chose to frame the subject of information blocking. And so let's talk about exceptions, which means in these cases, a provider can choose to block information. The first exception, and there are 3 main categories with subpoints under each of them. The first one is preventing harm. So it's really pretty simple. You can block the sharing of information if you think the sharing of that information would lead to harm to a patient or to another person, assuming certain conditions are met. The actor must hold a reasonable belief that the practice will substantially reduce the risk or harm. The actor's practice of exclusion must be no broader than necessary. You can only exclude the key pieces. You can't go beyond that in what you choose not to share. The actor's practice must satisfy at least one condition from each of the following categories. At least one condition from each, meaning all of these categories: type of risk, type of harm, and implementation basis. That's a technical piece we can crawl around another time, more than it is a novel idea. The practice must satisfy the condition concerning a patient right to request review of the individual determination. So there has to be an appeal process. Why is this all necessary? And I'm raising this question now for just preventing harm, but it applies to each of the others. Why would actors block information? Well, a lot of it was a sense of it proprietary. I own this information. It's about you, the consumer, but it's my information, and I can do what I want because I'm the provider. That's one dimension. Another dimension is competition. I don't want to provide that information to another provider because that might contribute to or be a part of my patient switching to that provider, or from a vendor side. I don't want to share information because I want people, in order to have access to that, to use my technology platform. So those are all reasons that we're trying to work around. And the first is preventing harm. You can share, you can hold back information without breaking the rules if the purpose is to prevent harm. The second is if there's a privacy exception. It will not be information blocking if the actor does not fulfill a request to exchange or grant access to information in order to protect an individual's privacy. And I see I mistyped it up here, but that's the idea. The key then, we'll see on the next page, it must fit within one of these four categories. You can prevent information from being shared if a precondition is not satisfied. So if you have to have, as your policies, a consent in place in order to share that information, and the patient hasn't given you that permission to do it, you haven't met the precondition, you don't have to share it. An HIT developer of certified technology, not covered by HIPAA. So that gets into earlier. We talked about the US DCI, that official set of information that is covered by the Cures Act, and that defines what is certified health information. So if the HIT developer is capturing information that's not a part of that data set, not a part of what's covered, then you don't have to share it as well. It's not personal health information as defined by the Act. Denial of an individual's request inconsistent with, and here we have some other rules back to HIPAA relating to addiction, and I'll just leave it with that. We've covered it. You can crawl around this act. It basically says denial of an individual's request for their EHI, electronic health information, that is consistent with the rules that specifically say you should not share certain information in certain circumstances related to addiction and mental health. And finally, respecting an individual's request not to share it. If the patient or consumer or their caregiver says, I don't want you to share it, you can honor that as well. These aren't required times not to share. These are saying, if you are not sharing for these reasons, you are not held in violation of the sharing rules with respect to privacy. Finally, there's a security exception, and I find it interesting to separate here security and privacy. Makes sense, but it's just, I'm so used to thinking of the two in concert with each other. This exception is intended to cover all legitimate security practices by actors, but does not prescribe a maximum level of security. This is a catch-all. If sharing the information could result in a security breach, allowing perhaps someone to get back into your system, then you can deny sharing that information. It's more of a catch-all than a prescriptive description of what the rules are, but those are the options for when you don't have to share. Otherwise, you do have to share information as a certified health IT vendor, as a provider. Note again, the patient is not covered. So the patient doesn't have to share anything he or she doesn't want to. I think there's a lot of work to be done over the idea of patient moderated health information exchange. And that, I think, is going to be a key part of one of the areas that we talk about as we look at the expanding or redefined role of consumer health informatics. Well, that's the discussion about health information blocking. Next up, we'll talk about fire and the implementation progress and the roadmap.